The world's gaze is on West Africa. I think we were all stunned and felt and still feel the pain of watching the delayed, fractured international response to Ebola that has recently come into quite a stark relief of cases that Dr. Kelly reviewed on our first day as a forum together, with over 14,000 cases, confirmed, suspect, probable, and also more than 5,000 deaths. And in mainly these countries, but we could add another country to this list, such as the US, experiencing having to deal with Ebola virus disease, EVD, and also cases that may not yet even be recognized or deaths that could be reclassified. As we watch the unfolding epidemic spread, I think we also were a bit confused at the almost somnambulant state of some of the agencies that we have counted on in the past. And today, our session with our panelists is going to be much more about the reality of the Ebola response, what we've done, how we're doing it, and really for all of us here today, a bit rolling up our sleeves to talk about what has worked and maybe try to avoid too many theoretical issues. Recall that on March 23rd, the World Health Organization published the formal notification of the Ebola outbreak in Guinea, and it was the largest documented and first recorded. And then researchers traced the outbreak to a 2-year-old child, an index case who died in December. Now, as Martina mentioned, the index case was confirmed in the Jean Mérieux laboratory, the INSERM-run laboratory in Lyon. And quickly the virus spread via travel to Liberia, Sierra Leone, Nigeria, Senegal. And the first confirmed case in Sierra Leone was a young woman who was admitted to a government hospital following a miscarriage in May. And then 5 months later, we have the WHO declaration of the FIIC, or the Public Health Event of International Concern. Despite the efforts of groups like MSF and others, we tended to have an evidence-free zone. And this is a term that I've heard Secretary Clinton use, referring to a situation where the reality of the situation is so far from the minds of so many. And so with all of this information, still the sense of an evidence-free zone that we were trying to work in. So how did it get so bad? There are many things we can talk about. These are a few that I'm mentioning to get our group stimulated in thought and conversation. But clearly, all the international attention was focused in Guinea with minimal follow-up in Sierra Leone and Liberia. The international community was essentially all packed up when the first reported cases appeared in Sierra Leone. And as we've discussed here in terms of public-private partnerships, things like coordination and communication have been and continue to be one of the most significant barriers to the success in halting the spread of disease. And this acting, as I know many of you feel working in this area, this sense of ad hoc or reactiveness and what we're able to contribute. Yesterday I shared with Kim and Clarion and Joe that I went to part of a meeting sponsored by the Paul Allen Foundation where Ron Klain, President Obama's Ebola coordinator and advisor, spoke. And he said he had hesitant optimism about the Ebola situation because of the new activity in Mali. And so as we try to coordinate And today I really hope that we can come up with some ideas of how we can work together on this issue, along with the global health security agenda that Beth did a phenomenal job of distilling for us, a very complex initiative, that we're going to come out with some optimism, but also the reality of the situation. Today, we're going to together bring clarity. By the informality of this, we're going to have our panelists speak, and then we're going to have you as our extended panel to ask questions and give your opinion, since many of you also work on this issue. And we want to look at mechanisms and valuable alliances between civil society, private entities, public institutions, and also as the forum on public-private partnerships for global health and safety. You know, an important thing for us is we want to evolve these models of public-private partnerships and inform the forum on the value proposition that I believe Laura Herman did a good job in describing on our first day together. We also want to think about meeting challenges of sustainable, partnerships that last beyond an acute phase, and increasing coordination of partnerships or within sector leads for greater efficiencies. Now, the forum is allowing me as the facilitator to just say a few things about the Mérieux Foundation and our Ebola response. Martina did a great job in describing this, so thank you so much, because I could not have explained it that well. But with the Reso Lab, things I'd like to point out are things like working with the ministries of health. All right, this is very, very important. Martina mentioned trust is important, but we're talking about the granularity of being able to say that you know the minister across the border, and maybe you call them even as you have a suspect case. And this is, as an epidemiologist, this is a very good way to start communications and move in a timely fashion, especially with unscripted situations that infectious diseases often present. So the Reso Lab, I'd like to point out, although beginning in 2009, the Mérieux Foundation was building and assessing that program even in Mali since about 2004, 2005, so more than a decade. These partners, I'm happy to say that this morning, at least from the U.S. side, we could add that the U.S. State Department is supporting some of our abilities to transport patients and specimens in Liberia and Sierra Leone and perhaps Mali, and that we have a vast gap here of private. I think the Stavros may be the only private group. So perhaps we can, do better at that. And I take responsibility as the CEO to try to do better at that. We talked in our group about pre-positioning of relationships and structures. You see that the West African Lab Network is literally pre-positioned. We're not saying we have to build a lab. It's there. Maybe you need to do some different things, but a lot of things are pre-positioned. That's another thing I'd like to talk about today. Are there things, even for the global health security agenda, that we could pre-position to allow us to fulfill the President's vision on that? When it comes to the Ebola response, we mentioned analysis of specimens, and that's huge. Getting specimens across borders, getting a confident, reliable result from a specimen. And also, we were able to provide expertise. People knew each other, like in this room, and they trusted the expertise they were sharing. Martina mentioned training in biosecurity and hemorrhagic fevers. Some of that is unique, but other parts of that information build upon biosafety and biosecurity. And then the international scientific partnerships that Joe and Pat have talked about, from academies, from institutions that scale up quickly to be able to respond to these. I'd like to mention just something about training, and this is very important. You notice the countries that we didn't mention that we were working in already were Sierra Leone and Liberia. We didn't have a lab network or structure there, but the trainers from across these porous borders are able to gain entry into the country, again, trusted relationships. And they can do things like manage the logistics of the samples, also when to and how to destroy samples, how to archive them, and how to protect the healthcare workers as they're handling these. We did offer throughout the ResoLab countries the free specimen transport and analysis, and even the packaging of these specimens is quite difficult at certain levels, and allowing people to have these rapid kits and the transport made a difference. Our panel today, I have met them over the past few weeks. It's been a pleasure. Adam Levine, who's on the phone with us, the Assistant Professor of Emergency Medicine and the Director of the Brown University Global Emergency Medicine Fellowship. Larry Sipos, the Acting Deputy Assistant Director of Defense for Force Health Protection and Readiness, and Joe Ruiz, a pleasure to have spoken to you these past few days, is the director of the UPS Humanitarian Relief Program at the UPS Foundation. Today with our panel, I hope that as the world gazes on West Africa, we're going to have a more clear view, a more clear gazing that's informed by what's happening on the ground. Let me just end with a few photos that are from Sierra Leone, the Kenema Government Hospital. And when I was with the Department of Defense delegation in Sierra Leone this summer, if you were to just see these photos, I would not have to explain to you more about what we need in capacity. Okay? So I'd like the group also to be realistic that if we are committing to build capacity, we have to be sincere about it. We have to be sincere over a long time period and find incentives with Ebola that maybe we haven't found incentives from other things from. This is the PPE station for the viral hemorrhagic fever ward, which was quite a premier ward in Kenema that dealt mainly with Lassa, which is also occurring now. And so that does not look like something that is going to be sustainable or scalable. We also have the quarantine area for people that, again, very simplistic. We understand more. We can't, blame people for not controlling something if maybe this is the point of excellence. This is the patient family area where patients would, their families would cook and wait for evidence and specimen results on the families. They had to be separated from the rest of the hospital because of the stigma involved. And we also know that these excellent scientists can want to do better and need help to do better with their patients and families. These are just discarded stretchers after a patient with Lassa or Ebola has been on a stretcher. They're discarded. It's in the open, but it is never used again. And the crematorium is part of the complex of the viral hemorrhagic fever ward. And lastly, as we have these discussions, again, beyond the theory, let's please remember the human toll of the outbreak. Whether it's the toll of Dr. Jacob Mafunda on your far left, who was head of WHO for Sierra Leone, who was removed from his post after people started to mobilize in late August and September. And then Dr. Khan, I'm sure you've seen on CNN in the white coat, one of the very young star physicians and for viral hemorrhagic fever in West Africa who died very early on. And of the remaining 5 people that I haven't mentioned, 4 of those people have also succumbed to Ebola. The young woman in the green top and blue pants here was also a Lassa survivor who was not able to return to her family and almost lived on this hospital complex, but she also succumbed to Ebola. So with that setting, I would be very pleased, Adam, if you would share with us some of your experiences, and I'm going to put up a photo of you so that we feel close to you.